Hi there, Dane here from ARC Health. Welcome to Remote Consultation Masterclass. This is a podcast where we catch up with leading healthcare professionals to discuss tips and tricks for carrying out remote consultations, as well as bringing you key nuggets of information for your CPD. Now you can listen to us on Apple Podcasts, YouTube, Spotify, or wherever you get your podcasts from. So I hope you enjoy the episode. Today I'm joined by Dr. Rebecca Robinson, who's an SEM consultant. So today we're going to be talking about a range of things, but it's going to include cancer and exercise, long COVID, and remote consultations. So Rebecca, thanks for joining us today.
Thanks very much, Dane. It's a pleasure to be here.
Before we get started, I guess, everyone likes to know someone's story to begin with. So tell me a bit about yourself and your career today.
So I'm a consultant in sports and exercise medicine. And usually when I say that, people ask straight away, what does that mean? It's a real range of work, as you'll know too, Dane. So I really spend half of my time looking after athletes who are at the highest level, usually aiming for an Olympics or in professional sports, and we're trying to keep them healthy because they often come down with injury or illness, and trying to rehabilitate them back to be the best they can be. However, on the other side, exercise medicine is really all about trying to optimize health, and that's looking at the general population and also people who've had long-term illness, whereby they actually may have made a good recovery from the initial illness, but how do we try to get their general health back? Because we know that being fit can help on a lot of illnesses, a lot of prevention. Also trying to optimize physical activity in the general population, because people are less fit often than is good for their general health. And actually in both aspects there's research involved. In the latter, there's certainly a lot of areas where we need to try and help this become part of what we do, especially in the National Health Service. And I guess within that, one of my interests therefore is in cancer, because that really is a long-term condition for many people now. One where we think exercise could be really, really exciting too.
Cool. So as with all sports medicine doctors, I guess that is a portfolio career of interests, and I guess a varied set of roles. But obviously we're going to talk about the COVID stuff in a bit, but let's start with the kind of cancer and exercise stuff. So you've actually piloted and run a service in the past, and you're still running a service at the moment. So tell us a little bit more about that. What's the service look like? Who is it aimed at?
So I guess one of the better ways maybe for me to try and explain it is like how this evolved. So when I was training in sports exercise medicine before I was a consultant, I had a great opportunity to travel abroad and see what was happening in different centres, because this is an area that is still growing. Basically, what we know is that exercise can be really good in cancer. We don't quite know why. We don't quite know what type of exercise, and we don't know how good it is in prevention or in secondary prevention or in actual treatment of cancer. And obviously that is not one disease, it's many subtypes. But basically I was really fortunate in Sheffield, which is where I finished my training in sports exercise medicine, to work in clinical research for a couple of years and basically work within the teaching hospital at the time. And what we really looked at there in terms of the research question was, what did health professionals think about physical activity? So those at the front line in oncology, really, so within the hospital. And in a similar way, that question has been asked in the patient group and more in primary care, to say, well, what actually do we need people to know? What do they know already? And the answer overwhelmingly was that people are very keen and understand the need, but don't quite know where to place this yet. So in terms of a service, what I've been doing more recently is working remotely as well as in person. And I guess the ideal I'm able at the moment to deliver in private practice, which is not my ideal in terms of where I want all of my work to do, but I'm very, very fortunate to work in a clinic with a brilliant team. So it's fascinating to be able to do that. I just want that reach to be for all patients. What we can do within sports exercise medicine is basically looking at a patient wherever they are in their journey with cancer. So often that's during treatment, but it can be before treatment, looking up to how fit they might have to be for an operation or to tolerate treatment. What happens during their treatment? How do they continue to exercise? Very, very significantly, and probably where I see most of my patients is after cancer, because if someone has done very well, which they often do, fortunately now from the treatment, they can often have what we call late effects, and these can be very significant impacting on their quality of life, such as looking at fatigue, but also looking at some other aspects like cardiotoxicity, which can happen due to the drugs that people are on. But we also see increases in problems like cardiovascular disease in a population that's had cancer, impact on their bone health. And actually lots of the questions come from all different aspects and all different types of cancer. Can I cycle when I'm having treatment for my prostate cancer? Can I swim when I'm on chemotherapy? What can people do? How to adapt to the fact they might not be able to do what they want to do. And that's just for the active population. So for those people for whom physical activity wasn't something normal in their life at a certain level before cancer, to sort of say, oh, well, you must exercise and get fit is sometimes seems a hard thing to say, but actually how can we enable someone to be a bit more active? And that might just be at home, in the garden, when they've had a cancer diagnosis. But alongside all of that kind of must come the clinical research to say, well, is this important and why? So in an ideal world, I'll see somebody at any of those stages. Often we'll have some markers in terms of knowing where all their scans are at. We'll be able to look at where their blood tests are at. In the world that I can work at in a clinic currently, in a private clinic, we can work with exercise physiology and physiotherapy. In terms of how that would translate into an NHS clinic, which I'm hoping to pilot quite soon, it'll be very interesting because actually, there is a cost. It is additional to the standard treatments that people have, but relative to the cost of the treatments that people have, it's really quite low. And if we can start to look at what that might mean to people's quality of life, the ability to be more mobile, to go back to work, I think hopefully we'll be able to say that it's really something worth doing. So
yeah, that sounds great. And I guess with that question, you mentioned that you're doing a lot of it remotely. Have you noticed it's had an impact by going remote, or has actually been beneficial, and kind of what have you learned from that?
I think in terms of, obviously, like this year has had a massive impact on people's treatments, sort of like negatively, because people can't have or haven't been able to have their normal treatments in the same way. For me personally, remote has been eye-opening in a good way. I didn't really consider remote medicine before. I deliver remote medicine in the cohort of athlete patients that I have. Usually you have the same patients from an Olympic cycle right through, because basically you've got athletes who are fit and healthy, but you're kind of providing that sports medicine care up until the Olympics. So once you get to know them and work with them, sometimes you'll follow up with a phone call or a video call. But to do that for full sports and exercise medicine clinic appointments, at first I thought, gosh, it will be so different. I really underestimated, especially in the exercise medicine field, how much we learn still from the history. Also, suddenly I'd have a clinic where my patients were really spread across the country. And I think that's something interesting, because exercise medicine is a field that can apply to all illnesses, really. I was going to say non-communicable, but of course COVID is another area where we think that exercise medicine can be beneficial in the rehabilitation, and certainly beforehand too. But for example, in cancer and exercise, at any one time, there might be a lot or a small amount of patients that you need to see in one locality. And also it can be tremendously more responsive, because if the clinic I would normally turn up to on a Friday, say that they need me to come and see this patient who is struggling, then I can actually be there remotely much more immediately. So that's made life very busy in the sports medicine part of my job, but much more responsive. And I think actually maybe for a cohort of patients who wouldn't need or want possibly to come back into a hospital for another appointment, there can be a way that we serve their needs quite readily through remote medicine. So I think it's so
it's kind of opened up kind of the number of patients and the people that can access your service. And actually, you make a good point that I didn't consider, which is, I guess a lot of cancer patients might still have some form of immunocompromise. So actually, when you don't want them in these settings and you can do it from home, why wouldn't you?
Yeah, I think also it's been interesting. Something I've reflected on with some of my colleagues is sometimes patients travel quite a long way to come for an appointment. I've been kind of lucky to be based partly up in the Lake District recently, which is where I'm from, but not where I've traditionally worked. We don't have many big hospitals in the area. But for example, a patient from here would usually go to Manchester or Preston, sort of nearby cities, well, not that nearby, a couple of hours really, for their follow-up. So if they're able to have remote consult, well, gosh, suddenly they might have that half an hour to do some physical activity and rehab instead of traveling down, but also meaning sometimes that maybe health inequalities that we get due to geography are reduced. Of course, we do still have the issue that some people won't have the same access to video consults. And personally, I found the video consults much more helpful for me than just a straight phone call, because you can kind of interact a lot more. But again, interesting to reflect if that's just me or if that's the patients. Hopefully it's the patients.
No, definitely. And I think things are moving that way, aren't they? Like, for all the reasons you just said. Picking up on that point, the other point you made when you said non-communicable was kind of moving on a bit, was around, I guess, COVID and exercise. And I guess before we go there, obviously COVID's a big problem. That's why we're all doing remote stuff now. And I guess from a sport and exercise medicine point of view, you know, lots of people are asking us questions, including questions that patients ask in general practice, which is, I've got COVID. When can I return to exercise? When can I return to physical activity? What are your thoughts on that, and what are you doing with athletes at the moment?
So my thoughts are very much guided by the early input we've had from some of the specialists. There's some brilliant specialists that luckily I work within the English Institute of Sport, and luckily we're able to collaborate and work with. So I guess a couple of them that have led on this are Dr. James Hull, who's a respiratory consultant, Professor Sanjay Sharma, who's a consultant in cardiology, and there are numerous others as well who've worked in this field. But basically what was the big concern at first was that this is a new virus, but one that we know is affecting the lungs and causing inflammation in the area of the lungs and the heart, as far as that in a very, very basic terms, because we don't always know how. And I think, you know, there's been consideration, is there a degree of, for example, subclinical myocarditis in some, or we don't really know in some people because they might not feel ill. You know, some athletes have very, very mild symptoms, but from what we know about even asymptomatic patients having changed on their x-rays, it's basically on the very bottom line, it became a question of, let's not push people physiologically, as we just do by the nature of high intensity training for elite athletes. Let's not push through any symptoms that they have. So early on, it was incredibly helpful to have this guidance that just basically said, any symptoms, just rest, and rest for 10 days. I think that was Dr. Hull who first moved at that point, and then backing it up with some of the evolving science. And again, it's brand new virus, as everybody listening to this will know. We have so perilously little evidence, which at the time we start to look to build it, obviously now we're going to a second phase probably of lockdown, and just to learn about how it affects the athletes. We can't get them into outpatients for routine screening, kind of the same if there are high pressures on the NHS, but 10 days of absolute rest was put forward, and that was really to protect the cardiorespiratory systems. After that, there was a period of time proposed, 7 days, whereby you get back into activity gently. So basically we're talking about runners just walking, getting into that light aerobic activity for at least a week. Now, if people have developed symptoms and they haven't settled in 10 days, you've got to wait. Can't just start again at 10 days. You've got to wait till they totally settle. Then you start that 7-day return. In elite sport, it's brilliantly easy, although obviously it needs the whole team to understand it. But when we've got physiologists, we can sit down and make a plan and say, well, let's get someone just being active. Let's monitor their heart rate, and more importantly, probably how they feel with regards to recovery, because we know that fatigue can be a big factor. So in a best case scenario, if we get someone feeling good and they feel like we're actually holding them back, but we're getting no kind of spikes in their heart rate that have been picked up in that first week, and they're just getting back adapting into, if they do strength work, body weight work, then the next week we kind of move back into some steadier, if it's a runner, steadier runs, or cycling, or if it's somebody, you know, I work with boxing, so they might get back into a bit of training, so that might be the bags and pads sort of thing. Somebody in a boat, so with canoeing, they might just get back on the water and start increasing there. But at every step, we're able to take a check and say, look, if you're feeling worse, we want to back off, because again, it's probably more anecdotal and case-based than bigger studies at the moment, but it does seem that if people start to struggle with fatigue and carry on, then that's where it gets trickier to settle down again. I would say as well that I've seen quite a few patients, and what's been really fun, I would say, I work in this clinic in London called the Centre for Health and Human Performance, and because I was really quite worried about what athletes would do, and because I compete and run quite a lot, I know what runners do. We try and get back as soon as we can. I think, well, a virus or something is gone, let's carry on. But because I was worried that general awareness that we really had in elite sport might not be as pervasive into people that do their sport for fun, but obviously why would they wouldn't read the rule books, because there aren't any really. Basically, we put a clinic on that's still running, actually, that's a non-charge one, just to look and see patients with COVID. And to be honest, I learned an awful lot from that. And one big thing I've learned is from some of the patients who had presented and said, well, actually I had what I think was COVID, or they'd had a test. A couple of weeks later, I tried to get back into sport and I tried to do a couple of sessions, and gosh, I was really, really tired. And then I had to back off again for a week. So that kind of pattern of it just not settling like a normal flu might, but settling eventually, was one of the things that I'd seen. And one of the things since then that in that clinic, we've been able to formalize a little bit more what these athletes do. And then I know we're going to mention a little bit about long COVID later, but again, in that scenario, just trying to help support any athlete that comes into a situation where they've had COVID, they expected they were getting better, but actually they've got symptoms now that are impacting on their life in general, but also in that sport.
Yeah.
So it's been quite busy.
Yeah. No, sounds it. And I think, as you said, the evidence is constantly evolving at the moment, isn't it? So, these decisions around guidelines for when can you return to exercise is fairly pragmatic, and I'm sure will change. So just to summarize what you said, just because a lot of people in general practice do get asked these questions. So if they've had COVID symptoms, it's going to be 10 days of rest, but it's got to be at least 7 days clear of symptoms before they can start back, and then they've got a week of slowly progressing back up, haven't they, essentially?
Yeah. So I mean, like, if they've got to day 10 and the symptoms have all settled, then they can go into that first week of gentle activity going forward, but basically got to wait until that point. If that's longer than 10 days, got to wait till that point. Do for some people, fortunately, if they get mild illness, they will probably say, and some of the athletes I work with, they're like, oh my gosh, that's could be doing more. But actually what we want in that first week is getting to the end of it without feeling extra fatigue, because the body's already been under a physiological stress because of illness. It's, to a degree, we should probably respect the body more when we push people through training anyway. But it's that gradual coming back, and hoping that people will just actually enjoy feeling more well, really. And most people who aren't elite athletes have other stresses in their life, like work to balance, which again always adds on to tiredness. So with work and family, not to say a lot of elite athletes don't have this too, but it's just respecting that there's only so much that we can adapt to physiologically, psychologically as well. So I think it's a helpful paradigm, and it has been very, very helpful the last few months, for sure.
And is there any point at which you're thinking about, actually, when would you say someone needs to actually get further tests and investigations done and shouldn't continue down the kind of return to play route?
This is something that, again, the English Institute of Sport have really led on and has been really, really good. So if we've got athletes who, after a couple of weeks longer than we think that they should have had symptoms settle, we can really look into what's happening with their health. So personally, I've tended for someone who's like an elite high performance to run an ECG, if I can, just to get a baseline. I have had some athletes who've then had issues with palpitations and just kind of feeling their heart rate was higher, or it looked like it was higher for a given intensity than the amount of deconditioning that they'd have had. So, they've lost time from training, but we would expect the heart rate to be in a certain area and it suddenly looked higher. So that's just something that is something that I've been doing. It's not currently set in stone, but what is definitely recommended is if you've got somebody whose symptoms are going up towards, say, 30 days from onset, so basically they've had that first period of being unwell, but after an extra kind of couple of weeks still unwell, then we definitely want to be investigating, looking at a chest x-ray, looking at an ECG. In elite sport, we are looking at high resolution CT. We are looking at cardiac MRIs, and I think there is decent evidence that, unfortunately, we have seen a number of people, not fortunately within sport in the UK at the moment, but in the general population, we do know that some people are experiencing myocarditis And we really, with that, you've got to rest for 3 months and then gradually get back into it, but you don't obviously want someone to train through it. There have been a number of people with pulmonary emboli and thrombi that have been seen sort of in the heart as well on scans. So we want to be not over investigating, but investigating thoroughly when appropriate, because I think it's just that consideration that the mixture between a highly inflammatory and it appears prothrombotic condition in some people mixed with high intensity sport. So basically we're lucky in the English Institute of Sport, we can now send people to a really great setup which is being run in London for all those elite athletes to go through. But the same would apply for me, like I'd be directing patients to say, go see your GP, and if it can help by writing a letter and saying, yeah, we want to do these tests, because then I think that should hopefully help to support people. So again, we're hoping that the majority of people who are fit and active may have less severe symptoms. I mean, that's what we appear to be seeing, but in the case of people that love their sport, it's really important they get back to it, but get back safely. So there are some other tests.
Cool. Okay, so we'll come back to that, but hopefully you guys are happy with that, and we'll pop a link in about the return so you can have a read about some of the EIS stuff that's published. So we've talked about the normal return to exercise, physical activity, but also when you might want to investigate. So these are the prolonged symptoms. Perfect. So I guess the last point to pick up on is the age-old long COVID, which seems to be coming up more and more. So I guess my first question is, what is long COVID?
So I don't know if I want to put it out there and like define it, because I guess we're all still trying to do that. I guess from a personal perspective of what I've seen, it's a constellation of symptoms. Fatigue seems to be really one of the predominant features. Basically, someone that's had coronavirus by definition. So, and again, we've got the testing. We do have a lot of people that never had the testing earlier on, especially like in lockdown, but presume they had symptoms, but whereby these symptoms just either haven't gone away. So again, probably not like a definition that's in print, but like from what I've seen, it would be those patients presenting with quite significant fatigue, sometimes loss of concentration, quite often relapse in the symptoms of COVID that they had, especially with regards to fever, especially with regards to myalgia. Sometimes, and whether this is a feature of long COVID or complications of, but there have been people with quite significant impact in terms of neurological features, or I don't know, I expect quite a few GPs will have seen people with skin manifestations of COVID. So it's basically this syndrome that appears to be lasting much, much longer than the acute infection. And I think, like, on a personal point of view, when I've seen patients, there is a high element of distress because likely they don't know when it's going to get better, and also because it's impacting on their life, and the fatigue side too, which is again something I'm used to seeing with cancer related fatigue patients, and also athletes who have overtrained. There's an overtraining syndrome whereby they're just tremendously fatigued basically and can't attain the same exercise levels. So that's I guess that's my version of it.
Kind of, okay. And I guess we are seeing more and more patients with these kind of symptoms now, aren't we? So I guess the next question really for you is this kind of talk about long COVID clinics and COVID rehab clinics, and it's been mooted up and down the country, and a range of people are talking about it. And I know you were either looking at setting one up. So tell us a bit about what a clinic like that would do and what the aims are.
So this is quite an interesting one, again, because of working with a few athletes who've had long COVID, basically, but also because the opportunity has arisen to run a service which is going to hopefully happen in the next few months, a virtual clinic that's being supported by Sport England, which is brilliant. But it's looking at supporting patients, basically. I've mooted, and I think so what we're going to do is looking at that from the angle of sports and exercise medicine. And I think it's important to emphasize that this isn't about using exercise necessarily as the first thing to get people back feeling well, and that's understandable because we know in the chronic fatigue syndromes it appears to be does appear that the central nervous system is kind of the modulator. We just don't understand quite how. But graded exercise, for example, does have a place in chronic fatigue syndromes. But in this instance, I think it's more than that. It's looking at, it's really important for people to have physical activity and movement in their life. And we've got other aspects that are going to suffer if someone has long COVID and can't be as active, because we know that musculoskeletally, they're going to become weaker. We know that we've got to keep people healthy from a cardiovascular point of view. So trying to shore up those systems would be a place to help with some exercise interventions, but also really important to go as slow as that patient can tolerate. And that's where, you're looking at things like seated exercise, you're looking at just like movement in the day. But really important for me in that is in a sports medicine consultation, you just find out where is that person at in terms of their life, their general health, what's the minimum that they can do, but also really important to work in a multidisciplinary team. I guess I really like how in sports medicine we can work with physiology, and it doesn't have to be really clever metrics, but it can be that rate of perceived exertion. And sometimes the physiologist can also work as like a personal trainer and to just help give someone someone to listen to, somebody to support them through that journey. And the other sides of it are obviously the psychology, managing and dealing with the symptoms that they're getting, but also really, really important. So this is quite a small service in itself, and this will be done remotely, but we also want to link in. So, if we're worried about someone that has these symptoms, but they've got prolonged breathlessness, that needs to be investigated. So it might be just being able to signpost them, whether that be to their GP or directly to services to get further test and investigation. So we're not trying to do all of that complex side, but to recognise when that might be something that needs further intervention too.
Sure. Cool. No, that sounds great. So I guess to probably finish off, where's that clinic going to be running?
So this is going to be virtual. It's run from Sheffield, but it will be virtual. So in terms of the initial phase, we're going to have like a small cohort to run through, but hopefully then after broaden it out. And the main thing is that this will be free of charge for the patients, but they should be able to refer in. And obviously those routes will work out soon, but it might be that people can be referred themselves and or from their GP too.
Cool. And if people want to see you or speak to you at CHHP, is that just via the website, or is there a better way?
They can definitely email, probably easiest to email info@chhp.com. I think at the moment we are going to keep on running a non-charge COVID clinic for athletes because unfortunately, I'd love to say we didn't need it anymore, but obviously we're still living in a pandemic, and if we can provide that support, then that'll be ongoing. And we're going to be running, probably should have mentioned too, we are actually doing a long COVID clinic in that clinic. So the setup there is sports exercise medicine, but because in there we have the CPET, cardiopulmonary exercise testing, and we've also got some really good physiologists and physios as well. So what we can do there is support patients. We're getting the first one sort of through at the moment, but basically finding out where they are after COVID. And some people want to get back to fitness, and obviously we can check where they are compared to where they were before their illness. But again, anyone recuperating from long COVID, we can just be a bit more hands-on in terms of supporting them back too. Perfect.
All right. Well, Rebecca, firstly, thanks really much for joining us and for your time. That was really useful. And I hope you guys found it useful. So we've covered a little bit about cancer and exercise. So again, do have a look around your area to see what's available for patients that either kind of during cancer treatment or maybe even post for primary or secondary prevention. We've also talked a bit about COVID and return to exercise. And we've talked about the English Institute of Sport guidelines that were published, which is around that kind of 17 days of a slow phase return with rest. So again, we'll pop the links in. So do have a look at that. And then we've talked about this concept of long COVID and maybe one role being exercise, but obviously it's a bit wider than that as well. So again, do have a look around those, and we'll pop some links in with this podcast. And of course, if you do want to see Rebecca or read more about her and stuff, do check out the CHHP website, and hopefully you can check her out there. All right, thanks guys, and see you on the next one. As always, do keep in touch with us for future episodes by clicking the subscribe button on Apple Podcasts, YouTube or Spotify. See you on the next one.